Howdy, everybody, and welcome to our March Grand Rounds. I'm Harold Lehman, and Paul Najee is our Grand Rounds Director as well. Before I introduce our speaker, just to remind you all that we have a number of courses starting off in the fourth quarter. We have decision support, natural language processing, and imaging informatics. Jonathan Weiner from our very own School of Public Health. He's a professor of health policy management and health informatics and is the founder and a co-director of the Johns Hopkins Center for Population Health IT, Population Health Information Technology at Bloomberg. He's an internationally regarded researcher and policy analyst who's worked in several healthcare system domains. His current work focuses on the integration and application of big data, the medical, insurance, public health, and social service sectors for the population and community-based analytics and interventions. And to be honest, he's been in the field of population health informatics before it had that name. And in fact, he's one of the founders, not just of the Institute, but also the very notion of thinking about this sort of work as population health informatics, even though the word information technology was used in the name of his center, because the word informatics was not that well received at the time. So without further ado, Dr. Weiner will explain us a little bit about where AI is these days in population health. And take it away, sir.
Well, first of all, Harold, thank you so much for the kind words. And also Paul and Chris and Stacy and to BIDS. And especially thank you to all the people that are joining us live and those that may be listening via archive. We're going to be moving very quickly, but I also want you to know that this is a learning activity. So most of my slides have URLs, and I'm happy to share slides with you. And this is a starting point, not an ending point. I have been in the field and I have a lot to say. Hopefully something that will share ideas, get people thinking in a domain that's very important to me and many of you, and that is, how do we take all of the digital data available to us and improve the health of populations? After all, that's why most of us are in the business, even those of you, and thank you for that, working with individual patients. The goal is to have an impact on as many as possible. The focus today will be not only on medical, but also social determinants of health. We could have a whole lecture on that topic alone. And AI, yes, the I in A is lowercase because with the sans serif, it looks like AL. So, I often use the small AI. So we will indeed talk about the buzz, the Gartner hype, but I hope to leave you with a balanced view, if pragmatic and realistic, of some of the challenges in applying AI, and that many of the issues that people turn to AI, really, they need to turn to informatics or analytics, not just AI. I have no relevant disclosures. So my goal for today is to focus on the field of population health and social determinants. Frankly, the two go together because that's one of the definitions of population health, that we're not focusing just on the medical care. Most of us only get medical care to improve our well-being and what we can do with the body that we have. And so health is really an overriding concept. AI is a very confusing term. There are about 5 academics. You'll have 7 definitions of AI, but I hope to share with you at least some ways of looking at it. I'm a big believer in frameworks, paradigms, definitions, not that you have to accept them, but that you understand them and see what people are using. So you'll see that. Yes, there is a buzz, a hype around AI, and I hope to clarify that and leave you with at least some definition within the analytic framework. Although I will touch on some of the other uses of AI. I'm basically an analyst and do modeling and predictive modeling and use data for that purpose. We will also try to take the big picture and understand how all of us can contribute to a learning health system that's evidence-based. And many of us are either in an academic institution or you're here with us today, and thank you for joining, interested in topics where we can use science. I don't have all the answers, but I do hope to offer some guideposts and ways of thinking. And I did found and am joined by many wonderful colleagues at the Center for Population Health IT, CPHIT, and it's IT, not informatics, because that's where the money was at the time with the ONC Herald. But we, of course, do deal with informatics and data science. And one of the things that we'll see is the terminologies are very confusing. So let me start off with some unifying frameworks, not about AI, not necessarily about data science, but why we are in this business, and that is data science, informatics, computer science, whatever your preferred term is. And here is one framework that my close colleague Hadi Karasi and I and others published in JAMIA to help define the field of population informatics. Now, public health informatics has been here for a while. The field of population and public health informatics are closely related, but public health officers, very challenging task, God bless them, focus on communities, on populations. And this is sort of the demand side, that is the patient, as the economists would say. We have patients, we have consumers, we have smaller target populations that may be a target of a health maintenance organization or a hospital, but the health officer is concerned about the entire community. We're in a medical environment, whether or not you're a clinician, doctor, nurse, you're within a single hospital or health system, and here is an entire medical care system. We could give a whole lecture on the challenges and advantages of medical care versus community care, public health. But the main point is that population health informatics deals with both the medical side and the population health side. And those of you that focus on clinical informatics, the focus tends to be on the interaction between a clinician. There are other definitions, but this is the one that I'll follow. I just want to highlight this previous I guess it was 2017 bills on publication, bills on the 2012 framework that I developed as a commentary that went somewhat viral. It actually was a commentary I wrote for some colleagues in Israel, which was the most wired at the time health system in the country. I'm sorry, in the world, the country that had the most wired system on the globe. And this reminds us, I don't need to tell many of you, and by the way, this is an interesting and important audience. I realize some of you are quite expert in informatics, data science, and even AI and computer science. Some of you are clinicians or public health people, and it's a blending of both sides that is important. So I will try actually to try to understand that the group that I'm talking to has both components. So here, just a reminder that we are surrounded by an ecosystem, or I call a digital milieu, both with community health resources as well as medical resources. As I mentioned, virtually all of the slides have a URL at the bottom, and I would be happy to share my slides with you so that you can learn. If there's a URL, it either was something we've published or someone else published, and you may share it. If there's no URL, I'd request that you keep it internal as an educational, because this is still work in progress. Social determinants of health, SDOH. One could give a whole Gartner hype cycle discussion on the newfound importance, at least in the medical community. Public health and social community has long known that housing, food, a job, a safe environment is higher on the Maslow hierarchy than visiting your medical doctor. But obviously, all working together to support the health and well-being of both individuals and communities is critical. And in population health and public health, we've known that for a while. And now I've never seen more involvement in social factors among hospitals and medical colleagues, and I think that's wonderful. We have a long way to go. In my opinion, we're only 10% on that journey. So this is a framework, and is another talk, but a framework that we've offered for blending social determinants into the analytic framework. And I encourage all of you relevant to your medical or public health or human service framework to take the data, it's out there, and find out how we can bring in, whether or not it's clinical data, non-medical organizations, or direct from consumer information that ultimately can go to the triple aim, that is improving health, lowering costs, and bettering care. The quadruple aim we'll get to in a moment they've added provider well-being. But this is a framework for how one thinks about social determinants of health, the use cases, whether or not it's the CDC's buckets. The CDC talks about buckets of prevention, which is another way of the framework I gave in the previous slide, whether or not it's the individual level, the provider denominator level. Our health system is very concerned about the patients that rely on the Johns Hopkins health system. And now they're also concerned about the community. So there are 3 buckets. There are many stakeholders. This is really a collaborative game, whether or not it's the patient, the providers, the health system, and money is all important. 95% of all the resources in the US health system flows through Medicare, Medicaid, the private insurance companies, and of course the government agencies. But what we'll talk about today is this middle part, this middle use case, a little bit of the patient care, a little bit of community, but we're focusing today on predictive analytics, modeling, and the role of AI. So these are all foundational. I'm not going to read these definitions, but I have put together from other sources population health, including both sides, the medical care and the public health. Social determinants is non-medical. Big data, oh, there are 20 definitions of that. More on that in a moment. This is a cool Venn diagram. I like Venn diagrams because nothing is ever isolated. I don't like spreadsheets as much as I like Venn diagrams. I couldn't find the source of this, but this shows the overlapping nature, whether or not it's AI, big I, small I, machine learning, more on that in a moment, big data, predictive analytics, yikes. Are they the same thing? Are they different things? As you'll see from this Venn, which I more or less agree with, but not completely, they give AI an awful lot of credit, all the way this flesh-colored oval here. They say data science overlaps, but it's separate. I might or might not agree. Notice that AI is different than big data, and big data overlaps and is similar to predictive analytics, and predictive analytics is similar but different than statistics, and question and answering, that is chatbots, and machine learning and deep learning, yikes. But the main point is there's an awful lot of overlap. And anyone that comes to you and says, well, I do big data, that's not AI, or I do analytics, that's not big data, or AI, I've been a statistician for 20 years and I don't do much AI. The fact of the matter is it really does overlap considerably. And the best team is one that really is comfortable in these multiple domains. And frankly, AI alone, although there are experts in that and there are things that are quite important and unique that add to the party, really are part of this, whether or not you want to call it data science. By the way, informatics, of course, is a well-known term in departments of informatics and biomedical informatics and among clinicians who have chosen data science. It's less well-known, the term informatics, just a reminder, outside of the medical domain. But that's neither here nor there, other than we should all be humble when it comes to labels. All right. This talk isn't about IT, about terms, about data science, or even bytes and bits. It's really about how we can improve well-being, both of individuals and health of communities. And that's what we need to be reminded of. Let me provide some frameworks, things that I have used as foundational in my journey. And I hope that some of you will at least consider them as your journey. The ONC, the Office of the National Coordinator of Health IT, a unit of HHS, still very important. It was a lot more powerful when President Obama sent out the door, what was it, $30 billion as part of meaningful use? They don't have that type of money anymore, but they're still very influential. I loved this, I like a lot of well-done paradigms. I love this paradigm that they offered, and this was a continuum. First, let's look at the people in the middle. We have patients, we have individual practices, we have populations, and then we have publics. Again, population is a targeted group, public is everybody. And they remind us that we're serving all, they say 4, and that's true, 4 different denominator groups. And each of you sometimes have different emphases. At this level, it's about access to care. At this level, it's about safety. At this level, it's about sharing data. It's only notional, imaginary, that we really have data across populations and public. Only about 15% of the electronic health records in this country are interoperable, whatever the number is. But it's certainly not most, probably not Johns Hopkins. Are you looking at all of the data on the person? So that is a reminder. When one does quality, these arrows represent the tasks that we do, and it's bidirectional. I might have done it a little bit differently. I wouldn't have put analytics right here. But the main point is I'd encourage you to look at this when one thinks about the big picture. Informatics is unique to these gray bars here. Standards, interoperability, security, supportive frameworks, governance, and ethics. So these are things that informaticists or people that think about the infrastructure are doing. And without the ONC and many of the colleagues here, we would not have this framework. I'm a big believer as a health services researcher who's always been a data user and creator of knowledge that the learning health system, LHS, is common among implementation scientists, quality improvement scientists, health services researchers. Some of you may be familiar with this, but there is a foundation, and the foundation is very much a social economic. Here we have technology, social, scientific, technology, policy, legal, ethics. So all of us, whether or not we're on the social science side or the technology side, need to work together. Here we have the classic from knowledge to practice to new data and a continuous quality improvement cycle. And here again, we have the outcomes, the things that bring us to this field. Improving health of populations, improving individual patients, and this is the quadruple aim, now particularly in the era of COVID, provider burnout. So now the triple aim is the quadruple aim. The main point I wanted to mention is our role as data scientists or information scientists, and as we apply AI, isn't just to do things with the data or apply the AI. It's really to be part of, either this framework or that framework, but to be part of the whole puzzle, and that's what we bring to the continuum of our society. All right, that's the first part of the talk. I'm keeping an eye on the clock here. Now, I do want to acknowledge that there's so many important aspects of data science. I am going to jump ahead quickly to the AI and the analytics, and I'll assume both some knowledge of AI as well as some people that don't have any knowledge of AI. But before we do that, just a reminder that, what was the old adage, garbage in, garbage out, so digital garbage in, digital garbage out. We must be very sensitive. Yes, AI and analytic technique can help us identify problems with data, but there's nothing like interoperable, standardized, comprehensive, meaningful data to support this entire endeavor. So hats off to those of you that work in that domain. That is not a domain necessarily of computer scientists, but we need a computer scientist to join with the informaticists. So I want to make that point. And Hadi Karatsi, thank you, Hadi, for doing a lot of work in the population health and informatics domain. This is a slide that I love. There's a whole educational funded by ONC activity that CPHIT and Harold was key on as well. So the next couple of slides I'm going to jump over because I want to get to the data modeling and analytics and AI as promised. But we can't forget about steps 1, 2, 3, 4, 5, 6. Even the AI is really just in one step. So we have to develop the data. We have to prepare and curate the data. Yes, we have to develop training sets and learning sets and modeling and data modeling and AI and features. I'll get to that in a moment. And then, as I'll discuss, a lot of the AI has not been validated and evaluated. I'll show you that. In fact, the punchline, a good portion of the AI in predictive modeling, when compared against other gold standards, is not necessarily in advance. Some is, and we want that. But so the whole model and validation is something we must spend time with. And I'm speaking to the choir. Some of you are experts in use of knowledge and how that cycles back. So we must not forget about box 1, 2, 4, 5, and 6 as we jump in to the modeling and data. In fact, I love a lot of my computer scientists, but they sort of put all of these into the all else bucket. And I would posit to you, they're not all else bucket. They're actually, in some cases, more important than the modeling. More on that later. 4 other slides. Also, Hadis, thank you, Dr. Karazi. You've all heard, or some of you have, when one talks about big data, there's the V. V as in Victor of big data. One of the V is volume. There's a heck of a lot of it. And trying to manage it, we need database and data science techniques to manage the data. Yes, AI can compensate for data that are large and messy, but it is not the solution. The next slide reminds us of a variety of data. Increasingly, we're working with 5, 6, 7, 10 types of data. And most analysts only are expert in 1 or 2. And nothing gets me peeved more than, let's throw all the data in and see what happens. Yes, sometimes the AI can help, but we really need to understand the different sources of data and unstructured data, person data, and none of it, as a health services researcher and one that's done a lot of measurement development, a lot of the data leaves things to be desired. AI can help, it can't compensate. Moving ahead with the V's, the speed. And we have some colleagues that are very good at ICU data and things that are coming every 10 minutes. In population health, our speed is not quite as fast as you find in an ICU, but knowing when the data was and doing time analyses and time series is also quite challenging. And a lot of that is done ahead of time. Some of that is done analytically. And the last V I want to mention is the garbage in, garbage out. There is a lot of noise. Those of you that are clinicians working hard on the EHR know the challenges in the EHR. I and some of my colleagues are among the first that use claims data. And by the way, claims data tend to be more complete, if less comprehensive than EHR. In the first 10, 15 years of of claims data, you couldn't trust the ICD code at all. Now everybody gets paid on the ICD code. So it's an example of understanding the data quality. All right, that was fast, but what's following is going to be faster. By the way, I am going to stop at 10 of the hour to allow interaction, and I hope that this will be the beginning, not the end of a dialogue that we might be able to have, and one that we can continue elsewhere in the institution. All right. There is no complete agreement with AI, but I was quite surprised that it's definitional. I was quite surprised to learn that the United States Department of Health and Human Services now has an Office of the Chief AI Officer. Yeah, I didn't make that up. Within the last year. So, I can understand that there's an information officer, informatics officer, data science officer, but AI officer. Especially since, in my opinion, 90% of the issues that people are worried about with AI are really not AI issues. They're data issues, automation issues, digital issues. But let's read the definitions that they offer. Artificial intelligence. Most people, by the way, use a big I, but that looks an awful lot like an L to me. So I like the small I. But AI enables computer systems to perform tasks normally requiring human intelligence. That's standard. It's okay. In the analytic domain, that's only partially true, but I'll accept it. And machine learning is a type of AI that gives computers the ability to learn without being programmed by humans. I'm not so sure, because often they talk about supervised and unsupervised AI. Unsupervised meaning let the computer go on its own. I'm a big fan of human interaction and supervision. But these are their definitions, even though I have a comment, we'll go with that. This is my slide. In the context of health and healthcare, when someone says AI, it's really a catch-all all the time. When someone says AI is good, AI is bad, AI is the answer, they're really talking about data science, informatics, automation, take your pick, and 2/3 of the time, more on that later, when they actually are talking about AI analytics, I would posit to you that old statistical or epidemiology or econometric analytics was just as good, if not better. But it is true that robotics and chatbots and that part of AI, one could argue, should be handled a bit differently. Today, for this talk and the rest of the talk, I'll be focusing more on data mining and analytics, and let me focus on that. I do hats off to those of you in MRI, AI imaging, and ophthalmologic imaging and robotics. but we won't talk about that today. So we will talk about machine learning, AI, and other types of analytics. Now, natural language processing, text mining, when what, 60% of the EHR is unstructured, is critical. Some people call that AI, some people call that machine learning. Hats off to those of you doing text mining and NLP. It is certainly related. I will not talk so much about it today. This is one of the many, many. I'm going to have two or three or four frameworks for what is AI, what is machine learning. It appealed to me. It isn't necessarily the only approach, but you'll see that on this one, machine learning with deep learning and predictive analytics, again, these aren't necessarily mutually exclusive, is what we'll be talking about today. NLP is separate. I'm not going to talk about speech. Expert systems is sort of a chatbot, although if you use ChatGPT, you'll see it's not quite so expert. Robotics and vision are sort of separate, but they are indeed under the AI domain. A lot of the controversy is here. But when one talks about population health, when one talks about predictive modeling, clinical decision support, one tends to be talking about this. This is sort of intermission. You can't have a talk nowadays on AI without ChatGPT. OpenAI. I asked OpenAI what it thought about this talk, and it gave me a B- answer. It wasn't bad. It doesn't have a personal opinion. They thought that population health AI was good. They thought I was a little cynical by using the term buzz, but maybe we should think about ethics and social implications. Overall, it liked the title. Hey, they get some points for that, and if you haven't, you should try it. I'm always worried as a teaching professor about will students use it. But anyways, that's a little intermission. Some more comic relief. I went to the OpenAI company, something called Dolly, using the same technology, asking it for a graphic AI-supported population health analytics in Maryland. I'm not sure I like that too much. A little unsettling. Here's the cyborg. Here's a Maryland flag. That doesn't look like the state of Maryland, does it? I didn't like that. I didn't want to end up there. I read somewhere that any talk online, I guess this is going to YouTube eventually, will get a lot more votes if it has a dog. I like corgis. I took a sabbatical in London, and my boys came back with a corgi when they were 10 years old. So I said, all right, give me a corgi dog looking at a population health map of Maryland. That isn't exactly Maryland, but sure enough, that is a corgi. So anyways, if my advice to you, if you're using any of the graphic programs, stick to dogs and cats. All right, that's our intermission. Let's go. So machine learning. I could not find any graphics or framework that was the same among different authors. So you put three machine learning experts in a room, you'll get 7 different frameworks. But I do want to highlight this concept that I raised already about supervised and unsupervised. That means letting the computer go on its own is the unsupervised. Supervised learning is frankly the only way to go, in my opinion, in most cases, where you, that is the human teams, the people, work with the AI, that is the computer, using certain rules on its own. And that isn't so different from the old days. In fact, I haven't seen really good explanations for how the old stepwise regression, blockwise regression, recursive partitioning is different than the new AI. Certainly neural nets, naive Bayes, random forest. Some of you have heard this. By the way, there are 30 different AI techniques, but the main thing to get across is, sure enough, the computer using brute force repeats various analyses, sometimes with help from the human, sometimes not. Reinforced learning is basically you give little Reese's Pieces or M&Ms to the computer after the fact and say, good, well, it's not a boy or a girl, but good computer, and that's called reinforcement learning. So it's a type of supervised learning after the fact. I am not going to go into all of these. In fact, there are probably only 5 of you online that could program this on your own, but there are 100 or more of you online that could pull any of these from various R, Python, et cetera, packages. So we all need to be sensitive to it's easy enough to apply, but not always easy to understand. No talk on AI would be complete without talking about deep learning, also known as neural nets. Brain scientists among you might see some axons here, but it's basically brute force that looks for quote, hidden layers, hidden relationships, the yellow. I don't, the terminology, I suppose you put 4 academics in a room, you'll get 7 sets of terminology. But input layer, what's that? Those are independent variables, the factors that really matter. Output layer, what's that? Those are dependent variables, outcomes that really matter. These hidden layers are unique. You don't find that, although social scientists have path analysis, psychologists have factor analysis, where we do look for not using the red to explain the blue, but we have intervening variables, as we health services researchers will call it. But using the brute force, the computer scientists have developed useful techniques that can look for relationships that aren't apparent from comparing the red to the blue. It is an advance, but like any advance, sometimes you need to be careful. I found this an accessible article. It is an article using the SEER cancer registry, where they developed a neural net, a simple neural net, thank you, using input layers, otherwise known as risk factors or independent variables that we all recognize, particularly clinicians among you. These are the factors they used to develop a predictive model to determine who was going to be alive or not alive from thyroid cancer in the near future, using this large denominator population. I mean, what I've described isn't necessarily an AI technique, but using AI approaches with hidden layers, this is an accessible article, and there are a few others where epidemiologists, clinicians, and computer scientists work together. So it is, I believe, an advance, but not so fast, not so fast. Computer scientists, to their credit, realize that most of the rest of us don't understand all of these techniques. So all of the boxes I showed you before are put into, gee, maybe I should explain it. And kudos to them for worrying about that. There's a whole domain. If you look at the URL on the bottom, that's the source of the graphic I borrowed. There's actually literature reviews of how well computer scientists do explaining AI, and they call that XAI. And yes, as things get more complex, that's this axis, low to high, they become less explainable. So the point is, less complex decision trees are highly explainable. Very complex, in this case, the neural nets I showed you before, are less explainable. Well, this is something not new to any of us in the health policy, public health domain. Whether or not it's AI or logistic regression, you've got to explain what you're doing to clinicians, to consumers, to politicians. But this is one of the biggest challenge that we all must be sensitive to as we use newer techniques. And here are some other examples along this continuum of explainability. And sure enough, all of these are potential alternatives. You may or may not know that Oracle, the formerly database management company, now is actually the biggest EHR company. It's bigger than Epic by 2. They bought Cerner, electronic health record company, a couple of years ago, a year ago. Oracle, you might think, is just relational databases. They're into AI. And I like this graphic. You can find it here. This is a reminder that machine learning isn't just about predicting categories or predicting numeric values, classification, regression, but there's a whole bunch of other techniques. Again, computer scientists use the term feature for anything that they can measure, variables. One area that I fully support using AI for very complex EHR records or claims records or databases I use are millions of patients with thousands of individual items. So what's millions times thousands factorials? A lot of possible combinations. So although I would never trust AI to look at all 100,000 ICD codes or 100,000 drug codes, or take your pick of any other variables, we often need help in bringing the clusters down, discovering relationships. So not using it for the actual prediction, but using it to, they call it feature selection, feature extraction. I would call it understanding data, data assessment. I call it data sleuthing. So just hats off to folks at Oracle for reminding us of the other different applications of AI, again, in the analytic framework. Looking at the clock, let's talk a little bit about this, one of the elephants in the room. Very often you see the latest study in any clinical journal from, whether or not it's from a statistician or a health services researcher or a computer scientist. They only present the random forest analysis or the neural net analysis or gradient boosting. They don't present the non-AI logistic regression analysis. This was from an electronic database in Singapore. Again, most other countries do better than we do with interoperable data, although we're catching up. 6 years of electronic health record data for the population of Singapore. They're trying to predict cardiovascular disease, kidney disease, diabetes, and hypertension. But what drew me to it is that they actually showed AUC, again, the area under the curve, rock curves, trying to show sensitivity, specificity, accuracy. This is something that most, an evaluation that most AI people don't do, but they did something else. They included non-AI along with the AI, and guess what? The non-AI was in almost all cases, not all cases, but in most cases, was the same or better. So, we need to slow down and don't assume just because we're using that new program that it's going to be better. In fact, this is a little dated. I look forward to finding something new. The epidemiologists, clinical epidemiologists tend to be realists. And this was a very nice systematic review that says machine learning is not, underline not, superior to standard logistic regression, especially when the study has biases. That was a really interesting insight. So each of these is a different type of AI technique. They compared the machine learning to the logistic regression. So in other words, it was 282 articles like the one I just showed you before. And when you look at bias, the results are all over the place and often favor machine learning. When you look at, in other words, machine learning makes itself look good when you're not really taking into consideration all of the inappropriate aspects of the study. When you are controlling Prisma, really doing a apples to apples comparison, just as often machine learning is better than regression. So you should be from Missouri. You should always be a little cautious of whether or not the AI is better than the non-AI, especially if it's not explainable. All right. Looking at the clock, I'm just going to introduce you to the Center for Population Health IT, CPHIT. We say CPHIT. We have a very comprehensive web page. It includes a lot of articles. That's the best part of our web page, which is a good thing to say. We have a lot of interesting things. My colleague Hadi Karatzi and Elham Hatef and Chintan Padja and Elise Lasser and others. A lot of interesting things. Our focus tends to be on new data sources, making EHRs useful for population health. Today, with only 15% of them being interoperable, we have a ways to go. Some of you have heard of the Johns Hopkins ACG system. If you haven't, you can learn more. That's not the main focus of this talk. But it is a measurement system that's widely used around the country. I think we're up to 25 and world, 25 nations. And it is basically a way to classify ICD codes, diagnosis codes, and drug codes. And we develop many predictive models, usually not with AI, but sometimes we're starting to use AI. But my main point is that this is a tool, and tools like it, that AI or not, you need to include. The next slides, I've chosen a few interesting things from CPHIT. Here's a slide, a study led by Elham Hatef and other colleagues, Hadi as well. Thank you, folks at the health system, for sharing the data. What this says, this reminds us that if you're looking for social determinants of health, we have a long journey to take. This was before COVID, which is probably good for a data set, and only 0.64% of the Johns Hopkins EMRs include structured data. Well, most of you that are clinicians appreciate that more than 0.64%, less than 1% of the people we serve have social determinant factors. The notes were a big advance using NLP. And today, there are many activities. We have one or more projects working with many of you where we're developing predictive models, predictive analytics, focusing on social factors. If you're interested, let us know. El Hamatef is key on that. This is one example we did where we did use some accessible machine learning, and we compared it to standard linear regression. And what this says actually is they're all about the same, except when you get into certain outlier groups, bias groups, and the OLS, the standard non-AI, did not do very well for the lowest decile. So to me, this shows and is proof to me that for certain applications, AI is worth it. AI is worth it, but not necessarily blanket. The reference is there if you're interested in. This is an analytic activity that we did with the VA, one of the best electronic health record interoperable in the country, where we did geo. We linked social data in with the EHR data, looking for the impact of social determinants. Here's the reference in the American Journal of Preventive Medicine. I'm just trying to give you a flavor. I don't expect you to take away, but these are models. And if you go to the CPHIT site, you'll see many models, only some of them using AI so far, for doing box 1 through 6 of Hadi's graphic, and trying to follow the learning health system and the other framework from the ONC, but using big data and using analytics. So I'm going to jump ahead. I've already made my point on, because I want to leave question and answer. This is Hadi Karasi and our team has spent a lot of time working, showing when is the data more accurate with claims only, when is the data read, the data diagnoses are in both, but only a relatively small number of codes are in the EHR only. For those of you that work with EHRs, and I'm grateful for how much better EHRs are today, just a reminder that we have a long way to go. Claims obviously are not satisfactory for a lot of clinical research, but just a reminder that accuracy is important. I'm going to jump over. We've done a lot of work with Maryland Health Department and CRISP, one of my favorite organizations in the state. I wish more states had interoperable data like we have. It's not perfect, but we're among the best in the country. We've done a lot of studies, including this important but sad study looking at opioid overdoses, which are going back up again, by the way. But we've linked prison data, medical examiner data, hospital data, insurance data, and that's the wave of the future and is essential to population health. And yes, AI is important, but not as important as bridging the data and standardizing the data and doing something about the data. I do want to, again, if you have not used ACGs before, I want to let you know that we're trying to integrate it more and more with Hopkins data and other databases. If anyone has ICD codes, if anyone would like a starting point for your AI or other analytics, we'd be happy to share that with you. Just let me know. All right, I'm going to, I now want to, about 5 more minutes, have an eye on the clock, Harold, and to end up with a few sort of messages, and then we'll have an open discussion. And then I also invite any of you to get a hold of the slides. Just send me an email, and you can learn more on most of the URLs on the page. So I and some colleagues coined a term e-iatrogenesis. And I saw this morning there are 80,000 hits on Google, so it's gone someplace, and 250 citations. I'm proposing a new term, e-iatrogenesis. Some of you know iatrogenesis, the core, is about medical harm. E-iatrogenesis is, the damage that data potentially can use. There's a lot of concern, and no talk is complete, particularly a public health talk, about AI without talking about harm. I just want to highlight it to you. I love this title. AI in this British Medical Journal editorial, they say, is augmenting inequality. And this is a great graphic. This is a good overview of the cascading effects of health inequality and discrimination manifest in the design and use of artificial intelligence systems. Wow. Now, I do think that 80%, 90% of the things they're worried about with AI, just like I was taking away some of the benefit of AI, I'll also take away some of the blame of AI. a good amount of the criticism is really could be leveled at informatics or analytics or logistic regression or predictive modeling. So it just shows that one can do damage at a population level or an analytical level or just about any level uh, in discrimination. And my favorite is analyses that look at different racial groups and say, well, these people don't need that service or this service, because after all, our models say they're not coming to the doctor. Well, they're not coming to the doctor because they don't have access to the doctor. So in baking that into a model doesn't make a lot of sense. That is not unique to AI. I'm also very pleased, and if you're not aware of it, you should. Our friends at the Office of the AI Health Officer of HHS have what's called the DHHS AI Playbook. So to their credit, many organizations, HHS is obviously an important one to health, now have a white paper on what all of us should do, what all of us to do. It's a lot more balanced than some of the just analytic focused. It talks about how one, and frankly, it's not just about AI. I wish people would come up with a better term. It's about the use of digital information to health and social, because that's what HHS is, activities as they impact people's lives. AI is part of it. Data and informatics is also part of it. Okay, last two slides, right on target. These are my end points that I'd like to leave you with. And it's the beginning of the journey, not the end of the journey. But I've given you, I hope I will give you a map and some signposts. And I love when people understand my point and don't agree with it. All I ask is you understand it and assess whether or not you think it's useful. Well, first of all, don't even think about population health or public health without big data and analytics. So we must use that if we hope to achieve a population-based system, an equitable system, one that focuses on value-based. That buzzword is familiar to most of you, but not all of you. Value-based is a buzzword, not just looking at what we do to people, but how does it contribute to health and well-being. We now have the digital data. Let's use it. As I said, everywhere, it's not just about the AI or even the analytics. It's about data preparation, curation, linkage, messing data. I'll get to the AI in a moment. So we can't just say, oh, wow, look at my 5 different AI techniques, which is better? Yeah, that's important. But what about all the other aspects? One should never think about just looking at lab tests or clinical data for an individual with diabetes or a population with blood pressure or anybody with behavioral mental health. We've got to look at individual, social, non-medical. We've got to work together. I think, the idea of let's throw all the features into the computer and see what comes out, I'm not a big fan of that. Yes, the computer can see factors that I can't see, but let's start with things that make sense. My favorite early in my career, someone was all excited. They're proposing to put people with cancer along with babies in the NICU in the same clinical category because after all, they both use the same amount of money. And I said, I don't think the doctors that treat cancer and think and treat neonates are going to find that very useful. So we need to be careful. And, all the time people use 100,000 raw ICD codes as the feature. Not exactly. EHR, thank you for all of you who have contributed to 100% EHRs in hospitals and 90% in doctors' offices, but we're not there yet in terms of it being usable for population health. Frankly, we're not there yet for clinical analysis either. As you look at the EHR, remember that in most cases, you're missing 70% of the interactions that person has. In some cases, if you're at Kaiser Permanente or if you're in a Medicare Advantage plan here at Hopkins where we have all the data, that's not true. But we always need to be sensitive that EHR, which is going to be the new base, we have to do a lot better if we want to use it for population analytics. And that is one of CPHIT's main goals. NLP, natural language processing, text mining, so much of the data everywhere is non-structured. We must not forget about that. That hasn't been the main focus of this talk, but we've discussed it. Now, artificial intelligence, machine learning, yes, absolutely, there's some advantages. I'm very excited, and I'm working on 5 projects now that involves AI, but it's not a no-brainer, and we have to understand that it's a no-brainer, that it's better. Don't get too excited. We need to understand the advantages, the disadvantages. It's complex, it's transparent. And, how is the AUC, ROC, sensitivity, specificity, or other validation criteria. As Harold Lehman always teaches us, and everybody else, humans with machines are better than anyone alone. So we've got to, I call it, I mean, other people use the term HCI for human computer interaction, but I have found some people use the term HCI/AI, a lot of letters. But whether or not you call it supervised, reinforcement, or working together, that's really the only route forward. As I've already alluded to, I'm not so sure that AI will lead to better predictions. I do think AI will lead to help in clustering, extracting, selecting, and really understanding large big data sets better than not. I'm adding to my e-iatrogenesis turn, I'll call it e-iatrogenesis. We must be cautious about bias and privacy. And going back to the early slide of learning health system, the fundamental framework of big data and AI really goes back to societal frameworks. I teach a class in health insurance and managed care, and in addition to analytics, I've done Obamacare work. If you really understand what's good about American healthcare, what's bad about American healthcare, it has to do with our financial and organizational and policy and legal framework. I'm in the Department of Health Policy and Management. The same goes here. We need frameworks, we need legal frameworks, financial incentives. We need an infrastructure where the data scientists and the implementation scientists work together. So I'm pretty much on time. I'm easy to reach. If anyone would like to follow up, and again, if you want to learn more about ACGs or CPHIT, there are the contacts. And if you would like a copy of the PDFs of the slides, just send me a quick email. And Harold, over to you for question and answer if you would like.
Well, gee, thank you for giving a 45-minute course on AI. So that was appreciated. Chris or Paul, do you have any questions?
Just a quick one. Excellent talk, Jonathan. I remember Lucila Ono Machado published 15 years ago that logistic regression was mathematically equivalent to neural networks, at least nested logistic regression. It's just that the communities hadn't recognized that for decades because of differences in vocabulary between the statistical community and the computer science community. Do you think that phenomena is more common than might otherwise be appreciated?
Oh, absolutely. I think that, no, I'm not a statistician or a card-carrying computer scientist, but the output and outcome is definitely the same. I will leave it to some of our esteemed statisticians to identify the difference. I know that when I learned about using computer brute force with stepwise or blockwise regression or factor analysis, it looked an awful lot, or early recursive partitioning, it looked a lot similar to me to what's happening now with neural nets. So yes, I would agree with you, Chris, but I would defer to others that know more about the formulaic equations.
Excellent presentation, Jonathan. Thank you. My favorite book on the perils of AI is called The Weapons of Math Destruction. And it's an excellent book. And you really described a lot of examples for why we need to have explainable AI. But the book also was really promoted the idea of learnability as well as explainability. I see, what type of challenges or opportunities do we have to provide learnability into our AI tools in healthcare?
When you say learnability, you mean the opportunity to keep improving, or teaching others how it works?
No, as you see new data, you're able to then create, your model can evolve, as opposed to regulatory processes where the model's in a static mode.
That's my point, is that we may need advanced statisticians and computer scientists to help with some of the AI, but we need implementation scientists and policy people and lawyers and ethicists for the whole framework. And so a team made up of 5, 6, 7 disciplines to accomplish all the things you said, Paul, are critical. However, the computer scientists and statisticians need to be able to work with those other people, and they're not always trained in cross disciplines. And those of us in the social science likewise need to be able to work with the data scientists. And that's on a good day, one of the things about Hopkins. We play nice together with different disciplines. So thanks for that point.
Well, I think as we start seeing AI come in, I like to quote, physicians are not going to be replaced by AI, but physicians who are using AI will replace physicians who do not use AI. And I do see a real role for physicians who are using AI to provide feedback to AI where it sees AI providing an out of context answer. And in that way, perhaps enabling it to have some learning feedback loops.
In reinforcement learning, the good AI learning algorithms don't learn what to do, they learn what the value function is of the people doing the act. So if you want a car to self-drive, it learns the rules to, stay on the road, don't crash into people. How would we get an AI about population health to learn the values of good population health, to avoid the sorts of inequities and all those bad things that we don't want to happen? What does that look like?
That's tough. I mean, how do we get people to use the internet appropriately? How do we get them to health literacy? I guess you could say it's a type of health literacy or public health literacy. And certainly there's a lot of concern we all have in the financial, and people have, at least educated people have read about that. But I would think the challenges are about the same. But I don't have any great insights. By the way, I've just seen there's a whole bunch of questions. I'm going to do rapid fire. One question: can you get the slides? Send me an email, jweiner1@jhu.edu, and I can send them to you. Karen wants to know where IBM Watson fits in. IBM Watson, which did not do so well, is a consultant product that tries to give AI more credit than it deserves. But it does include the AI, and they attempted to put all of this in together. Very smart people, but I think they charge too much, and I don't think it's doing very well. But it does tie into everything I've said. George asks about yes. I mean, I did talk a little bit about SDOH data quality. It is a problem. The social determinant of health is probably data available in most of our databases is only 1/10 what's out there. So that means some people may be targeted as having social needs and others not, and that's a two-edged sword. On one hand, only some people will get help. On the other hand, is there a stigma? I don't have an easy answer. I think the question of making data more interoperable, useful, valuable, that will be all of our jobs till the end of our career in the next generation. So data entry burden versus AI analytics. Yes, doctors and clinicians are burnt out about putting in data. Can AI analytics help that and lead to more interoperability? Yes, I think analytics in general. We're working on a project now where we're using available data to suggest which clinicians should spend time doing surveys for social determinants. So I think that we've got to figure out ways to keep clinicians from burning out. David asks wearables and passive data collection. I didn't talk about that too much, but I think we have overload now with EHR. Imagine if we're all wearing chips in our underwear and the watches. Any of you that ever tried to work with Apple Watches or with the A device, I can't use the word since she's in my office, and try to pull stuff in with all of the Internet of Things, David. That's going to be crazy, but important. So I think that I've answered all the questions and I'm right on time. Harold?
So thank you very much. And thank you for all being so engaged in the discussion. And thank you, and see you next month, everybody. Take care.
Thank you for the joining, everybody. Bye-bye.